Hello everyone, Dr. Alex Vasquez here with our program on human microbiome and dysbiosis in clinical disease. This is the video series that accompanies the printed monograph. In that monograph, you also have most of the printed presentation slides, and you also have password protected access to more than 12 hours of additional video to help you understand and clinically apply this information. What I'm going to do right now is focus on what I consider to be the core highlights of the information. I'll walk you through some case reports so that we can apply that information clinically, because of course the emphasis of the program is the translation of basic sciences into clinical practice. You'll find this to be particularly relevant for patients with diabetes, obesity, insulin resistance, and cardiometabolic disease, fibromyalgia, chronic fatigue syndrome, which has recently been renamed systemic exertion intolerance disease. Also, I will discuss some neuropsychiatric conditions such as autism and chronic pain and depression. And of course, major emphasis will be placed on the autoimmune and rheumatic diseases such as psoriasis, rheumatoid arthritis, lupus, Sjogren's syndrome, and multiple sclerosis. This slide provides a listing of the core content, and you might also use this as a mental checklist. We start with a pretest, and that allows us to assess baseline knowledge. It also allows us to assess the overall effectiveness of this learning program. Then we have the printed monograph, and then of course now we are entering into the video series and the video presentations. After we've gone through the pretest, the printed monograph, and the video presentations, then we access the final exam, and that gives you a chance to complete the program and print off your certificate of achievement. So again, taking our focus back to the video presentations, we're starting right now with number one, which is pathophysiologic mechanisms. I'll also talk about microbes, molecules, and morphology. This slide provides you kind of a general outline of the presentations. Each one, of course, will have its own title and introduction. I'll go through a few necessary repetitions, such as notices, disclosures, definitions, and goals. Then we'll dive into the core coursework. That will include at least one contextualizing case. And then towards the end, I'll provide a summary review and we'll conclude each video. Generally, as many of you know, I try to present my information in kind of a conversational style. What I found with this new information on microbiome and dysbiosis is that it is so detailed and so intricate that if I deliver it in a conversational style, it will double the amount of time necessary to get through this material. So what I'm going to do instead is focus on just what I consider the most important highlights, recalling that you've got the printed monograph that provides a lot of the more intimate and intricate details. You also have, with that monograph, access to 12 hours of additional video. And you can, of course, with this video format, always pause, replay, and review the material anytime so that you can learn this material not simply at your own pace, but also to your particular level of expertise that you'd like to gain. So, for example, if you just want to go through the program, become familiar with the material, print off your certificate of achievement, you can certainly do that. However, if you want to review the material more than once, you can do that as well, and that allows you to define and actualize your particular desired level of expertise with this material. I think you'll find this to be a very efficient delivery system, and again, that allows you to use your time for other purposes or to gain additional mastery over the material. Few notices and disclosures listed here. All of this material is, of course, copyrighted. I publish this in my books, and some of the material is also protected by trademark. The scope of delivery of this information is intended for licensed healthcare providers. This is not individualized healthcare advice, and the doses that I list are for adults unless specified otherwise. Again here, overviewing the core material of the program, we've got the printed monograph, we have the graphics and presentation slides that are printed in the book. Now we're starting the video series, and then we also have the pre-test and the post-test. And I want to encourage you to look at the pre-test and post-test not simply as a hoop that you have to jump through, but as a chance to really understand and interact with the material at a deeper level. Additional notices and disclosures are provided here. I have worked as a consultant researcher and lecturer for Biotics Research Corporation. Some of the treatment recommendations I mentioned may be considered to be off-label or unapproved by the FDA. All of the content has been validated and sourced from peer-reviewed research. And of course, we follow some ethical guidelines in the formation of these materials, and you'll see the core ethical guidelines listed at the bottom of this slide. Again, the intended audience for this material includes health science students and doctorate level licensed clinicians. As we go through the material, I may reference an occasional magazine or newspaper article, but again, the core material is always sourced back to peer-reviewed medical research. We're all encouraged to practice evidence-based medicine these days, so I want to review what the four pillars are of evidence-based medicine, and those are patient's preference and autonomy, clinician's expertise and experience, scientific research, and the socioeconomic and clinical conditions in which we find ourselves applying this information to patients. Primary goal of this work is, of course, clinical action and clinical application. When I first started publishing and presenting on this material about 10 years ago, microbiome was not even a word in common parlance. These days, we see that word used not only in the peer-reviewed research, but also in an increasing number of articles intended for the general public. So, whether we are clinicians or the general public, this is a conversation that everyone's having these days. Everybody's talking about dysbiosis and microbiome. However, one of the things I've noticed is that beyond several commonly repeated concepts, I don't see this information really being translated in detail into clinical practice. And that was part of what encouraged me to go ahead and update and restructure my own information so that we could really make this very important information on the microbiome and the role that microbes have in health and disease actionable and applicable to our daily lives and to our clinical practices. For example, microbiome is a very important concept, but doctors cannot treat and correct concepts. The concept has to be deciphered into actionable assessments and interventions for it to have clinical value. As I state again here more briefly and perhaps more clearly, you can't do anything with the microbiome because you can't treat concepts. And microbiome is kind of a conceptual structure, we might say. We have to break that down and decipher it into things we can actually manage and apply clinically. Only when the concept is deciphered into a manageable set of the most important components can you then actually work with it. The goal is not to convert clinicians into immunologists, microbiologists, or inflammologists, but rather to define specific concepts and to describe consistent themes so that clinicians will be empowered to assess patients more accurately and treat them more effectively. So let's get into that structure and then into the material. What I think is needed here in order to understand and master the microbiome, or anything complex for that matter, is a structured approach, one that is well grounded and comprehensive based on pattern recognition, but also flexible and amenable to expansion in the future when we have additional information. I actually learned this concept from reading philosophy, and in particular the work of Friedrich Nietzsche. In his compilation of notes entitled Will to Power, which was published a year after his death, he wrote, "In order for a particular species to maintain itself and increase its power, its conception of reality must comprehend enough of the calculable and constant for it to base a scheme of behavior on it." So as we progress through this introduction, I'll show you the intellectual structure that I've developed for what I call the functional inflammology protocol. The second component in that protocol is addressing the microbiome and dysbiosis. On this slide, I show you an example of two articles that are available online, which I published back in 2006. And again, as I said before, the concept of dysbiosis is valuable in itself, and research on the microbiome is important. But these concepts lose their value if they cannot be translated into practical and actionable understanding. Clinicians cannot treat concepts. So again, what I'm trying to do is take my 20 years of study of this material and really give you the gems, the pearls, the highlights, and the structure so that you can apply that with clinical effectiveness. Moving on now into the actual core material, we're going to start with some definitions and terminology. Microbiota refers to the actual individual microbes, whereas microbiome is slightly more specific in talking about the DNA or the genome of those microbes. A popular estimate that I'm sure you've read is that the human body contains more than 10 times the number of microbial cells than of human cells, and that the entire microbiome accounts for about 1 to 3% of total body mass. That comes out to about 3 pounds or approximately 1.5 kilograms. The majority of microbes cannot be cultured. That's why we see increasing use of various technologies such as DNA-based testing. Symbionts are the bacteria that live in or on us and either have no effect or have a slightly beneficial effect. Pathobionts are bacteria that live in or on us and are particularly predisposed to become pathogenic in states of injury, mucosal breach, or immune suppression, for example. Probiotics are the good bacteria that we can consume orally in foods or in pills and powders in the form of nutritional supplements, and these have beneficial effects. Prebiotics are the food that actually fuels the growth of the probiotics. So, prebiotics, again, are a food source for the probiotic or good bacteria. And when we combine probiotics with prebiotics, we call those products symbiotics. Dysbiosis is commonly defined as an alteration in microbial patterns, which is kind of a quantitative or numerical description. And I disagree with that definition, and I'll show you my own definition. I think the definition of dysbiosis needs to consider not simply the microbial balance, but also the host response to that microbial balance. And again, I'll walk you through my definition on the following slide. Some of the terms that we use from immunology include antigenic, which is a contraction for antibody generating, and immunogenic, which is a much broader term, and that of course means immune response generating. Now I want to show you my definition of dysbiosis, and I want to help you expand your conception of dysbiosis as we talk about the microbiome in clinical practice. My definition of dysbiosis has been for many years that dysbiosis is a relationship of non acute, non infectious host microorganism interaction that adversely affects the human host. Typically, with dysbiosis, we of course do not see the classic signs of acute infection, such as fever, redness, or swelling. And usually, the location of active dysbiosis has no signs or manifestations, or such findings are nonspecific. For example, many patients with GI dysbiosis, even severe pathogenic GI dysbiosis, have no major clinical GI symptoms, just as patients with sinorespiratory or genitourinary dysbiosis do not present with manifestations of an upper respiratory tract infection or a urogenital tract infection. On this slide, I'd like to review with you some very important learning objectives, and these include understanding the role that the total microbial load plays in the genesis and perpetuation of what we used to call chronic inflammatory diseases, and which I'm going to encourage you to call sustained inflammatory responses. You know, of course, that when we use the term chronic inflammatory diseases, we're kind of resigning ourselves to the belief that the disease itself has a life of its own and it's going to be chronic. Whereas if we redefine it slightly, and instead of saying chronic inflammatory disease, we say sustained inflammatory response, then I think that gives us a chance to really engage with the disease process in a more active manner to understand and decipher and then address what are the factors that are sustaining this patient's inflammatory response. When we engage more actively with the material, I think that actually gives us a chance to engage more successfully in our clinical practices. We also, of course, want to be able to define dysbiosis beyond its microbial definition. And I think that when we do that, we'll end up with three core components that we can use in our anti-dysbiosis protocol. First of all, of course, we can always address the microbes. We can always just kill them off. I think that's a very simple and ultimately simple-minded approach, even though sometimes it's very effective, and sometimes that is the required and desired approach. But let's look beyond that. Let's look at other things that we can do as well. For example, if a patient has an inflammatory response to a group of microbes, or we could say their total microbial balance, what that implies is that their immune system is not able to adequately control or kill off those offending microbes, right? So typically what we see in patients who have this dysbiotic inflammation is that they have some level of immune suppression. Otherwise, they'd either be controlling or killing off their offending microbes. So, with an expanded appreciation of what is dysbiosis, and when we see dysbiosis as a relationship between the microbes and the host, one of the interventions then that we can use is to restore immune function or to optimize immune function so that the immune system does its job of either killing off or controlling these microbial populations. A lot of times, what we see in patients who have sustained inflammation as a result of microbial imbalance is that they quantitatively have more bacteria on their skin, for example, and in their gastrointestinal tract. So a very reasonable question becomes, well, why do they have more bacteria? And I propose to you here that it reflects a state of subclinical immune suppression, and we can do things such as stress management, nutritional supplementation to optimize their immune function. Another question that we can ask is that if these patients have a subtle microbial balance that's promoting the development and perpetuation of inflammatory disease, why isn't their immune system tolerating that microbial imbalance that another patient may tolerate without any problem? So beyond looking at the microbes, we want to look at the immune system. We want to look at why is the immune system not doing its job of controlling or killing off these offensive microbial populations. And we also want to ask the question, why isn't the immune system tolerating these benign bacteria? A lot of the bacteria that trigger inflammatory diseases are not pathogenic bacteria. They are benign bacteria. So, a question that we should ask is, why is the immune system in this particular patient so intolerant of a benign microbial stimuli? So, again, the main three components of my overall anti dysbiosis protocol include antimicrobial interventions, immunorestorative interventions, and also immunotolerogenic interventions. On this slide, I'll provide you more terminology and a little bit of the history of the development of my program. We first started talking about dysbiosis, as I mentioned before, many years ago. In approximately 2006, I published an article in a textbook called Integrative Rheumatology, wherein I discussed, I believe for the first time, the concept of multifocal polydysbiosis. Typically, for example, in the middle of the 1990s, when we talked about dysbiosis, we pretty much exclusively focused on gastrointestinal dysbiosis. Now, as you can see here, we appreciate several different location-specific subtypes of dysbiosis, and those, of course, include gastrointestinal dysbiosis, now orodental dysbiosis, sinorespiratory dysbiosis, parenchymal dysbiosis, genitourinary dysbiosis, and also cutaneous and environmental dysbiosis. In the bottom left of this slide, I've listed some problematic GI microbes that I've seen in my own clinical practice. These include Aeromonas hydrophila, Blastocystis hominis, Candida albicans and other yeast, Citrobacter rhododendron, which is another name for Citrobacter frundii, Dientamoeba fragilis, Endolimex nana, Entamoeba histolytica, Gamma strep, Enterococcus, Giardia lamblia, Hafnia alvei, Helicobacter pylori, Klebsiella pneumoniae and Proteus mirabilis, Pseudomonas aeruginosa, Staphylococcus aureus and Staphylococcus epidermidis, Streptococcus pyogenes, and other group A streptococci. In the second video in this series, I'll review with you the molecular mechanisms of physiologic and pathophysiologic responses. On the following slide, I'll show you a graphic representation of this material and the overall model. Again, we start with the dysbiotic locations, and those include orodental, sinorespiratory, gastrointestinal, genitourinary, and dermal, and then tissue, which includes bacteria and viruses. And then we can talk about environmental exposure to microbial components. I call that environmental dysbiosis. We can also consider microbial dysbiosis to represent microbial infections of other microbes, one relevant example being the infection by viruses of bacteria. So, for example, bacteriophages are viruses that only infect bacteria, and we're seeing in the current research literature some conversation about alterations in the virome of bacteriophages that are associated with certain diseases such as lupus and inflammatory bowel disease. So, from the summation of all of those locations, the body has to deal with and the immune system has to respond to all of these major microbial molecules. And I consider the major microbial molecules to be exotoxin, teichoic acid, endotoxin, or LPS, that stands for lipopolysaccharide that comes from gram-negative bacteria. We also have to consider the impact of viral DNA, as I already mentioned, for example, from endogenous viruses, exogenous viruses, and bacteriophages. We also have to consider the load of bacterial DNA, their antimetabolites, and other enzyme-derived metabolic processes and antigens, and also the other, for example, fungal elements and superantigens, all of which I call the total microbial load, which then contributes to the total inflammatory load. As a result of the body's response to that total inflammatory load, we either get physiologic responses or pathophysiologic responses, and I've outlined those for you here, and we'll just start again left to right. These can include mitochondrial dysfunction and, in particular, a subtype of mitochondrial dysfunction called mitochondrial hyperpolarization. Along with that, we see mTOR activation. We can also talk about central sensitization as a result of microbial exposure, bystander activation. We can also talk about haptenization. Haptenization is the combination of a microbial molecule with a human molecule. And when we combine a microbial molecule with a human molecule, of course, that creates a new antigen or a new immunogen, and that's called haptenization or neoantigen formation. A new antigen is formed in that process. We'll also talk about inhibited detoxification and immune impairment as a result of microbial exposure, and we can also talk about the enhanced presentation of autoantigens along with bystander activation. So, as a result of all of those factors interacting with the patient's unique genomic and nutritional and hormonal profile, we end up seeing certain patterns of disease, certain patterns of inflammation, and that's what we appreciate clinically. And I've divided those into certain specific clinical prototypes. These include dysbiotic encephalopathy, central sensitization to pain, fatigue, and depression. A good example of that is fibromyalgia. Also, immune complex arthritis, dermatitis, and vasculitis. And of course, one of the prototypes that we're all familiar with, and that is reactive arthritis and its autoimmune variants, such as ankylosing spondylitis and rheumatoid arthritis. On this slide, I want to reinforce the concept of the total microbial load, and I'm going to talk specifically about the total viral load. The total microbial load includes bacteria, yeast, viruses, bacteriophages, and endogenous viruses. When we talk about viruses, we have to talk about the number and quantity of those viruses, the region or specific tissues or location of those viral infections, and the level of activation, recalling that viruses are not active and cannot reproduce on their own. What's required is an interaction between the virus and the human host, and that's what determines the level of viral activation. And another important concept here is that of viral transactivation. Because some of the molecular mechanisms are similar among different viruses for their replicative process, the activation of one virus tends to promote the activation of other viruses, and again, that's called viral transactivation. Now let's look at the model I've presented for you here. Again, talking about the total viral load in this example. That includes exogenous viruses, endogenous viruses, and bacteriophages. One of my favorite ways of describing dysbiosis and dysbiotic inflammation is to say that often what we find when working with autoimmune and inflammatory patients is that they are having a pathogenic inflammatory response to a non-pathogenic microbe. And these days we would extend from non-pathogenic microbe to a non-pathogenic pattern of microbial either balance or imbalance. But again, what we see is an exaggerated immune response against benign bacteria in a lot of these inflammatory and autoimmune conditions. These very specifically include ANCA vasculitis, formerly called Wegener's granulomatosis, rheumatoid arthritis, ankylosing spondylitis, dermatomyositis and polymyositis, Sjogren's syndrome, psoriasis, lupus, and we also can consider again certain clinical prototypes such as reactive arthritis and short bowel syndrome, also called bowel associated dermatitis arthritis syndrome. I mentioned just a moment ago the activation of mTOR by bacterial debris, and you can see that modeled for you right here, where I talk about bacterial endotoxin or bacterial LPS interacting with a receptor called toll-like receptor number 4. When bacterial endotoxin activates toll-like receptor number 4, of course that triggers an inflammatory response, mostly mediated through NF-kappa B, but it also triggers an alteration in mitochondrial function called mitochondrial hyperpolarization. That predisposes towards sustained activation of mTOR, and as I'll show you later, we're going to look at mTOR activation as a primary driver of autoimmunity and sustained inflammation. Many of you, I'm sure, are familiar with my work on mitochondrial dysfunction and mitochondrial nutrition. One of the major influences on mitochondrial function is the microbial and dysbiotic balance that can trigger mitochondrial dysfunction, and I'll show you a few examples of that within this first presentation in the video series. When microbes and dysbiosis contribute to mitochondrial dysfunction, then of course that contributes to the overall clinical picture and the pathophysiology and the vicious cycles that again contribute to sustain and exacerbate mitochondrial dysfunction. Here, I'll show you a separate model, which is also somewhat related back to mitochondrial dysfunction, and that is the model of endoplasmic reticulum stress and the related unfolded protein response. So, a variety of metabolic insults, such as hyperglycemia, and microbial insults from viruses and bacteria, and xenobiotic insults from drugs or corporate pollution, all of these can act to trigger endoplasmic reticulum stress, and then endoplasmic reticulum stress triggers the unfolded protein response, which is a very nonspecific pro-inflammatory response. And this contributes to some of the disorders that we see in clinical practice, again, including mitochondrial dysfunction, low-grade sustained inflammation, oxidative stress, a pro-inflammatory response, insulin resistance, hyperphagia, and non-satiation. So this relates back to patients who, for example, have difficulty with dietary compliance. Part of the reason they have difficulty with dietary compliance is that they don't receive the same satiation signals that the rest of us might receive from consuming food, and as a result of that, they're always hungry. This relates back to something that we'll talk about in future presentations, and that is the concept of hypothalamic inflammation, which is partly triggered by microbial and metabolic insults, and also again from corporate pollution. Independent from this pathway that involves endoplasmic reticulum stress and the unfolded protein response, of course, other pathways can also get activated to contribute to the clinical presentation of these various disease phenotypes. So that was the quick overview and introduction to the clinical application of the functional inflammology protocol, which I find to be very effective for the correction of metabolic inflammation, allergic inflammation, and autoimmune inflammation. I consider those to be the three types of inflammation that we see in clinical practice. Again, metabolic, allergic, and autoimmune. So let's go a bit farther now and look at the overall intellectual structure, as I call it, of the functional inflammology protocol. The entire protocol, of course, is detailed in some of my larger books, but let's look at the structure and I'll show you how to basically do what's commonly termed plug and play with this structure. So here on the left-hand side of your screen, you can see a representation of the overall structure, and I want you to think of this structure metaphorically as representing a bookcase or a library, for example. And once we have the basic structure and we've memorized the basic structure for clinical application, then we can plug and play as needed and we can tailor different protocols to the individual needs of our patients. So, for example, in some patients, we really have to focus on their food and nutrition. In other patients, we give more attention to infections and dysbiosis. In other patients, we might give more attention to balancing their immune phenotype, that is, providing more balance to the ratio of T regulatory cells to Th17 cells. For example, we often need to enhance the T regulatory cells at the expense of the Th17 cells. In some patients, we need to focus on their mitochondrial performance, and we can implement certain protocols that are very specific and very effective for optimizing mitochondrial health. In some patients, we need to focus more on their lifestyle, and that includes sleep optimization and stress management, also getting them to exercise. In this case, I use sweat as a metaphor for exercise. In a lot of patients, we have to look at balancing their hormones, because a lot of hormones can either have a pro-inflammatory effect or an anti-inflammatory effect. So we need to assess their hormones and optimize those balances and those ratios in order to optimize their immune and inflammatory balance. And finally, of course, we're all exposed to xenobiotics due to lack of government regulation and corporate irresponsibility. Those xenobiotics or persistent organic pollutants have an effect on our immune system just like they have an effect on our mitochondria. And you can see direct correlations between metabolic illness, mitochondrial dysfunction, and the total xenobiotic load or the total load of persistent organic pollutants. Again, as I mentioned before, the dysbiosis component that we're talking about now is only one component of the overall seven-part protocol. I think you'll find that once you learn this material and have studied it sufficiently for clinical application, that this actually saves you a lot of time and improves your clinical success. And finally, one of the things I've considered recently is the way that this occurs to me is that articles and classes provide information, whereas books and extended courses actually have the opportunity to provide more than simply information. They provide systems of thought and intellectual structure. And again, I'm trying to contextualize our microbiome information within an overall structure. And again, you can see that represented here. So, for example, in clinical practice, we often deal with chronic, sustained, low grade inflammation. In the medical model or in medical school and our medical training, what we focus on is the pharmacologic suppression of that inflammation because we're trying to suppress these clinical manifestations, whether it's pain or fatigue or long term depression. So, for example, in the naturopathic and functional medicine model, what we do is focus on what are the upstream contributors to that low grade inflammation. And we often find that to be mitochondrial impairment and metabolic dysfunction, a pro inflammatory diet and lifestyle, multifocal dysbiosis that I mentioned previously, and which obviously is the focus of this course, psycho-emotional and physical stressors, xenobiotic immunotoxicity, immunophenotype imbalance, and again, hormone or endocrine imbalances. Those all contribute in concert to immune activation, which drives a lot of the clinical pathology that we deal with in our practices, whether it's obesity and insulin resistance or cardiometabolic disease, or allergy, asthma, eczema, atopic dermatitis, or the more severe inflammatory syndromes, which we call autoimmunity, rheumatoid arthritis, and lupus being two of the prototypes. Again, here, another graphic representation walking you through the FIND SEX acronym. Now, of course, you don't necessarily want to or have to write FIND-SEX in your chart note. You could write FIND-SET, exchanging the X for xenobiotics. You could use toxins as a T instead, and you could say find set as if you're finding a set of problems and solutions. FIND-SEX or FIND-SET stands for food, infection, nutritional immunomodulation, dysmetabolism or dysfunctional mitochondria, style of living, stress modification, sleep optimization, endocrine or hormonal imbalances, and again, xenobiotics or toxins. We need to consider all of those when we're dealing with today's chronic and sustained inflammatory disorders. I think that most of us are familiar with the traditional SOAP note, which stands for Subjective, Objective, Assessment, and Plan. This is a way of approaching patients, integrating their subjective information from their history with objective findings such as physical exam and laboratory and imaging findings. We combine those two components together to come up with an assessment, and on that assessment, we base our plan. So you can think of the functional inflammology protocol as a way of extending this in an organized manner so that you can apply this information clinically. Because now we know that we need to focus on food and lifestyle, infections and microbial imbalances. We can certainly intervene at the level of the immune system and promote balance. I call that nutritional immunomodulation. And the goal of that particular sub protocol is to optimize the balance between T regulatory cells and Th17 cells. We can affect dysmetabolism and dysfunctional mitochondria through specific nutritional interventions. Items in the fifth component all start with S, or at least the S sound, so that includes stress, sociology, psychology, and style of living or lifestyle. And of course, that includes sleep optimization as well, because we appreciate that when people are sleep deprived, they are in a pro inflammatory state and they are simultaneously immune suppressed. Number six, we look at hormone and endocrine imbalances. Then, of course, we need to consider the role of toxins and xenobiotics on inflammatory responses and metabolic performance because we know that a lot of these toxins promote the low grade inflammation that contributes to insulin resistance, which drives obesity and diabetes. And we also know that these toxins directly contribute to mitochondrial impairment, which is also known to promote obesity, insulin resistance, and neurodegeneration. So, again, we're going to focus right now on part number two, infections, microbial imbalances, and dysbiosis. So now that I've given you an overview of the protocol and an introduction to the way that this information can be applied clinically, let's dive into the details of dysbiosis and microbial imbalances, and let's talk about the actual mechanisms through which these translate into clinical disease. So right now we're going to start, again, this is video number one, and we're going to discuss microbial molecules, mechanisms, and morphology. Our contextualizing case for this first section is actually outlined here, and you can see that this is a 24-year-old patient who presents with mild cognitive impairment or brain fog, new and progressive multiple chemical sensitivities or environmental intolerance, new immediate onset food allergies manifested by oral and mucosal blistering, a progressive relative leukopenia, and a positive clinical response to a vitamin B12 injection. So, based on this clinical presentation, we did a comprehensive stool analysis, as you can see represented here. These are the microbial culture results. And what I'd like for you to be able to do by the end of this presentation is interpret these stool analysis results with the patient's clinical presentation. Again, feel free at any time to pause the video if you want more time to analyze the case and some of these laboratory details. Let's talk now about bacterial morphology and the clinical relevance. I'm sure we're all familiar with gram staining as a way to differentiate gram-positive from gram-negative bacteria. This is part of what helps us determine antibiotic selection. We note that gram-positive bacteria produce lipoteichoic acid or teichoic acid, whereas gram-negative bacteria produce endotoxin, also known as lipopolysaccharide, abbreviated LPS. Both gram-negative and gram-positive bacteria can produce peptidoglycan. Gram-positive bacteria produce more peptidoglycan, so a lot of times when we talk about peptidoglycan, we want to think in particular about gram-positive bacteria. But actually, again, peptidoglycan is produced by both gram-negative and gram-positive bacterial strains. So those are the two major categories of bacteria. Generally speaking, we think of gram-negatives and gram-positives. A lot of times we're not taught about cell wall deficient bacteria, and we'll talk about those in one of the upcoming sections. So again, common to both gram-negative and gram-positive bacteria are flagellum, pilus, bacterial capsule, bacterial cell wall, which is directly inflammatory and can promote the development of inflammatory arthritis, also peptidoglycan, and you see here, of course, the bacterial cytoplasmic membrane. Unique to gram-positive bacteria is lipoteichoic acid or teichoic acid, and unique to gram-negative bacteria is bacterial endotoxin or lipopolysaccharide. The clinical consequence of endotoxin is what I'm going to focus on for the next few slides, and these include inflammation, increased intestinal permeability, impairment of the cytochrome P450 detoxification system, impairment of mitochondrial performance, and pain sensitization via peripheral and central mechanisms. Let's use this article to exemplify and underscore the clinical relevance of bacterial endotoxin. The title of this article, as you can see, is Human Experimental Endotoxemia in Modeling Pathophysiology, Genomics, and Therapeutics of Innate Immunity in Complex Cardiometabolic Diseases. This was published in Arteriosclerosis, Thrombosis, and Vascular Biology in 2015. Let's look at two excerpts from this article. Increasing evidence suggests that the infectious, biome-related, or endogenous activation of the innate immune system may contribute to the development of metabolic syndrome and cardiovascular disease. They go on to say that during endotoxemia, changes emerge in glucose metabolism, specifically that means insulin resistance, lipoprotein composition, and lipoprotein functions that closely resemble those observed chronically in inflammatory cardiovascular disease risk states. So again, what's very clear from the basic science and clinical research is that bacterial endotoxin is a major driver of clinical inflammatory disease states. Endotoxin also increases intestinal permeability in humans. Let's look at an excerpt quoted here. Brief exposure to circulating endotoxin increases the permeability of the normal gut. The hypothesis is presented that during critical illness, prolonged or repeated exposure to systemic endotoxins or associated cytokines may significantly compromise the integrity of the gastrointestinal mucosal barrier. And I'm sure you know that we refer to that more casually as leaky gut, also termed increased intestinal permeability or intestinal hyperpermeability. So we assess that clinically with the lactulose mannitol assay. Lactulose absorption is increased in patients who have leaky gut, and you can take advantage of the rhyming pattern between lactulose and leaky to help you remember that lactulose absorption increases when patients have leaky gut. Likewise, you can also take advantage of the rhymes between mannitol and malabsorption and malnutrition. When patients have mucosal damage and villus atrophy, they're not able to absorb nutrients as efficiently, and as a result, their mannitol absorption is decreased. So I want you to remember that mannitol goes with malabsorption and subsequent malnutrition. As I mentioned before, in patients who have mucosal damage, for example, due to food allergies or dysbiosis, we often see an increase in their lactulose absorption and a decrease in their mannitol absorption. And that's because simultaneously their gut is both more leaky to antigens and less absorptive of nutrients. So we see a divergence and somewhat of a paradox there in that they're absorbing more dietary and bacterial and microbial antigens, but they're absorbing fewer nutrients. And again, that's classic for mucosal damage, villus atrophy, and what we more casually term leaky gut. So again, before we leave this page, I want us all to remember that bacterial endotoxin increases intestinal permeability in otherwise healthy humans. Let's look at one of the triggers of bacterial endotoxin absorption. And you can see here that a high-fat meal induces low-grade endotoxemia, and this is one of the mechanisms of postprandial inflammation. So, when people consume a meal or a dietary pattern that contains a lot of saturated fatty acids and long chain fatty acids, I'm sure we all remember from physiology that those long chain saturated fatty acids are absorbed through micelles and ultimately chylomicrons. Well, those chylomicrons within their center contain bacterial endotoxin. So you can think of those chylomicrons as being like envelopes that contain enveloped endotoxin from the gastrointestinal tract. So we can summarize this by saying high fat diets promote systemic inflammation and the clinical consequences like insulin resistance and cardiometabolic disease via endotoxemia. So a lot of times, we've thought of dietary patterns as simply representing nutrient and caloric variations. So we would say, for example, well, a high fat diet has more calories and that's why it contributes to disease. But now we know that it's an interaction between the diet and those microbes. A high fat diet exacerbated by bacterial overgrowth is going to lead to more systemic inflammation, for example, because you're going to see more interaction and ultimately, in this case, more absorption of that bacterial endotoxin that can be triggered by consumption of a high fat meal. So, if we promote low fat and moderate fat diets, we're going to help our patients avoid inflammation by helping them avoid endotoxemia. So I consider this to have been a very important article published in the American Journal of Clinical Nutrition in 2007. Now let's look at a follow-up study published in Gastroenterology in 2012, which led to the same conclusion. High-fat diet is associated with endotoxemia that originates from the gut. Again, diets with more saturated fat are going to promote endotoxemia and the subsequent pathophysiologic inflammation, whereas prudent low fat or moderate fat diets actually reduce inflammation through various different mechanisms. So, the action we can take is to promote a lower fat diet to reduce the postprandial endotoxemia and the resulting postprandial systemic inflammation. So let's look at a graphic representation of that material. We see that endotoxemia is going to promote intestinal permeability, but when the gut becomes more leaky, the gut's going to absorb more endotoxin, and that's going to lead to a vicious cycle here. Now, other things also contribute to this vicious cycle. For example, dental disease, gram-negative infections and colonizations. Leaky gut is also promoted by any type of systemic inflammation, food allergies, inflammatory bowel disease, dietary fructose, as well as dysbiosis and small intestine bacterial overgrowth. We also see additional endotoxin absorption from the gut in patients who consume dietary saturated fat, which I already showed you. Also in alcoholism, alcohol consumption can also promote a leaky gut, as can small intestine bacterial overgrowth, which is a form of gastrointestinal dysbiosis. So you can see that this diagram actually helps us clinically to understand inflammation and immune activation by breaking down and deciphering each of the components that leads to this self-perpetuating vicious cycle. So we see endotoxemia causing leaky gut, and we see leaky gut contributing back into endotoxemia. So what we can do with this information clinically is address each of the contributions to reduce the total inflammatory load here by reducing, in this case, the total load of endotoxin. I mentioned previously in the introduction that bacterial endotoxin can also depress hepatic cytochrome P450 mediated drug metabolism, or the detoxification pathway that also helps to clear pollutants as well as drugs. If this pathway is chronically inhibited, for example, by small intestine bacterial overgrowth, which promotes the absorption of endotoxin, then the clinical consequences that we would expect are that patients would have more sensitivity not only to drugs, but also to the chemical pollutants that they're exposed to in their ambient environment. Many of those chemical pollutants we now know contribute to cancer as well as complex metabolic disease, such as mitochondrial impairment and the resulting insulin resistance. This data, as you can see, was published in the British Journal of Clinical Pharmacology in 1997 and was actually a replication of a previous study published in Journal of Clinical Investigation in 1994, which led to the same conclusion that endotoxin administration to humans inhibits cytochrome P450 drug metabolism, and that includes xenobiotic detoxification. The clinical consequences that we would anticipate from this phenomenon include, for example, increased adverse drug effects and increased sensitivity to a polluted environment. Endotoxin exposure has also been shown to impair mitochondrial performance and muscle energy production. This article shows us that experimental endotoxemia raises blood lactate under aerobic conditions in humans, and the associated clinical consequences would likely include increased muscle fatigue and increased muscle pain in patients who have sustained low grade bacterial endotoxemia. I also showed you in a previous diagram that stimulation of toll-like receptor 4 by bacterial lipopolysaccharide could promote mitochondrial impairment, and specifically the subtype of mitochondrial impairment called mitochondrial hyperpolarization. Let's look at that data here. You can see here that the data clearly indicated that bacterial endotoxin induced an increase in mitochondrial membrane potential, otherwise known as mitochondrial hyperpolarization. What you need to know about mitochondrial hyperpolarization is that it increases free radical damage and promotes sustained inflammation, and at the same time, the electron transport chain of the mitochondria is impaired so that ATP production is reduced. So these biochemical effects translate into clinical consequences, and what we see is more inflammation and also more pain and fatigue. In the second column of this excerpt, you can see additional reinforcement and detail. Mitochondrial membrane hyperpolarization was induced by bacterial lipopolysaccharide. You can also see here a reduction in antioxidants, specifically glutathione, in the intracellular compartment. When glutathione levels are low, what we see are clinical consequences that include inflammation, increased free radical damage, and inability to detoxify drugs and xenobiotics, and also rapid biological aging. Because bacterial endotoxin promotes mitochondrial hyperpolarization and therefore chronic or sustained inflammation, when we're dealing with patients who have sustained inflammation, we need to address the microbial contribution to that sustained pathologic inflammatory response. So, what the science makes very clear is that bacterial lipopolysaccharide promotes autoimmunity by several different mechanisms, including mitochondrial hyperpolarization, enhancement of oxidative stress, NF kappa B activation, and mTOR activation, and all of that culminates in tissue damage and the clinical manifestation of autoimmunity. So what I showed you previously is that bacterial lipopolysaccharide causes mTOR activation. And what I want to do with this image is show you that mTOR activation actually promotes inflammatory Th17 cell activation, so we get more inflammation, yet at the same time we have a suppression of the T regulatory cells. So we see a bit of a divergence here with mTOR activation. We see more inflammation and less immune tolerance. The consequence of that is autoimmune type inflammation and the resulting tissue damage. Now, let's add more detail to the diagram, and you can see that other pathways are also involved and become part of the reinforcing cycle of this pathophysiology. You see here activation of toll-like receptor 4 leading to activation of NF-kappa B. Of course, that promotes additional oxidative stress and additional inflammation. In the bottom of this diagram, I've added some dietary, metabolic, and xenobiotic contributions to this pathophysiology. So one of the actions we can take when we're working with patients who have inflammation and autoimmunity is to reduce their total inflammatory load by addressing their total microbial load. During the introduction, I also mentioned that LPS contributes to pain, fatigue, and depression via central sensitization via glial activation. I actually learned this concept from Jeffrey Bland in approximately 1994, 1996 in one of his programs, Advancement in Clinical Nutrition, which had a very strong influence on my work, now manifesting as functional inflammology. So, what we now know is this, that endotoxin lipopolysaccharide promotes cytokine elaboration. And even if those cytokines are elaborated in the periphery, they readily cross the blood brain barrier to enter into the brain and have neuropsychiatric and neurologic effects. Microglial activation is one of the consequences, which leads to astrocyte activation, and astrocyte activation promotes excess glutaminergic neurotransmission, which promotes central sensitization, pain, and central fatigue. So, what the science shows us here is that hyperglutaminergic neurotransmission promotes depression, pain, central fatigue. Obviously, therefore, when we're working with such patients, we need to address the causes of glial activation, one of which is the microbial contribution to their total inflammatory load. So, to exemplify the clinical application of this model, we can address and remove the inflammatory stimuli. We can modulate glutaminergic neurotransmission by using certain nutrients, for example, vitamin B6, zinc, and magnesium. Vitamin B6 lowers glutamate levels, while magnesium and zinc actually change the glutamate receptor, the NMDA receptor, and make it less sensitive to glutamate. We can also directly address glial activation by using what I call an anti-glial activation protocol, and this includes nutrients such as vitamin D, the omega-3 fatty acids found in fish oil, and also polyphenolic and botanical antioxidants such as resveratrol, the polyphenolics found in green tea, as well as a diet that's rich in fruits, vegetables, nuts, seeds, and berries. These dietary and nutritional supplement components can work together additively and synergistically to reduce inflammation and disease burden. Let's look at a model of glial activation here from Frontiers in Neuroscience, published in March of 2013. What we see here is inflammatory stimuli, in this case modeled by bacterial lipopolysaccharide, activating toll-like receptor 4 in the microglia or microglia. These are immune cells located within the brain, and when these get activated, they promote activation and eventually degeneration of astrocytes. In the meanwhile, astrocytes actually promote more glutaminergic neurotransmission, and again, this is what promotes central sensitization, pain, depression, central fatigue, and also migraine headaches, and in some cases, seizures. So before we move on to the next more detailed slide, I want you again to appreciate that microglial activation is triggered by bacterial products, including endotoxin and also the resultant inflammatory cytokines, and that leads to astrocyte activation and ultimately to excess glutaminergic neurotransmission, which can promote pain, depression, central fatigue, migraine headaches, and seizure activity and neurodegeneration. On this page, I'd like to show you more clinical applications and more pathophysiologic details for clinical application. We see articles now discussing brain inflammation, for example, in autism. Previously, this was referred to as brain on fire in the conversation on neurodegenerative diseases such as Parkinson's and Alzheimer's.